Let's see. Well, you guys actually get to pick them, like strawberries in the summer. What do you want? C. diff, recurrent cellulitis, C. diff, recurrent C. diff cellulitis, herpes simplex, an unknown case in a student living abroad, or an unknown case in someone getting a TNF alpha inhibitor. We got 40 minutes. We won't get through all of them, obviously, but I like choices. You can vote with your cell phones or yell or whatever you'd like to do. B, I hear B, bravo. All the above. Jan will kick me out. That's too many worms for one morning. Anybody else? Cellulitis? Come on, you guys get to pick. B? All right, let's start with bravo. How about C. diff or cellulitis and C. diff? That work for you guys? All right, so we'll start with B. And we'll work backwards. All right, if you're following along. So here's a guy I met in September, one of many that I've seen, and many. He's 57 and a healthy guy. Had a motor vehicle accident, had some leg edema afterwards. I really don't know the reason for that, but I saw him when I was on consultations. He was hospitalized. He came in with a fever and a white count and a cellulitis. And he was on one of our general internal medicine services, so you could see what the workup was. They put him on vancomycin, and then kind of a predictable thing, they changed to ceftriaxone to metronidazole. White count went back up, so back to vancomycin, so kind of a back and forth with antibiotics. Got an MRI that showed cellulitis, but no abscess or no osteomyelitis. So here's his leg, red, hot leg. And when I met him, his wife was there, and she was delightful. And both of these people were just really nice people. And I asked him how this started, and he said, well, Saturday night we had our family over for a football game, and he felt fine, and he was cleaning up. So he was walking up the stairs, and wham, out of the blue, got the chills, and my legs started hurting. And his wife immediately chimed in, every episode is like that. Okay? And I said, well, how many episodes have you had? And almost simultaneously, like they had practiced this, they said, he's into double digits. And this is the third episode this year. So he had what, a January, June, and now September. So here's the question for you. What is this? Is this classic MRSA? Is this a classic Staph aureus infection, but it's not bad enough to be MRSA? Is this a classic streptococcal soft tissue infection? Is this a classic Erysipelas soft tissue infection? Or is it a classic Vibrio soft tissue infection? So vote now with your cell phones or however you'd like to vote. Okay, so we got Vibrio, MRSA, half and half. Strep comes in. So 3 people, 1 each, huh? All right. Well, good. And of course, staff has to be in there. All right. So let's go over a couple of these. So many of you, where you live, are certainly well familiar and have your radar up looking for Vibrio and the saltwater-related cellulitis. Huge problem, very sick, especially chronic liver disease, immune compromised. Erysipelas, freshwater soft tissue infections, very important. Staph aureus, MRSA, let's face it, MRSA has all the news. MRSA's sucked up all the news and PR, and I fear education when it comes to soft tissue infection. We are so MRSA-ophobic, and some of this drives less than optimal antibiotic choices, which is one of the things I want to talk to you about today. And as I talked here a little bit, everything kind of clicked. This is true blue right out of the book, the classic strep history for a streptococcal soft tissue infection. You don't need anything more than this history in order to sell you. Strep comes on like a shot. beta hemolytic strep comes on abruptly. People many times can just tell you to the moment almost what they were feeling fine, and then bam, at 11 a.m. my legs started hurting and I felt like I had the flu. Staph takes a while in general. Staph takes a while. And if you look at how these organisms work, it makes some sense. Strep gets down deeper, not always to the fascia, right above it in the subcutaneous fat where we have a lot of neurovascular bundles. And it gets its way down there, and then it can travel very, very quickly. When it's on its game, you know, it can travel as quickly as a centimeter an hour in the devastating infections, not a guy like this, but in necrotizing fasciitis. Staph, about a centimeter a day. So they're much different organisms in their toxins and their potency in general. But this history of I was fine and right out of the blue, my leg hurts is classic strep. So in a case like this, what's the most important aspect of acute management? Is it that vancomycin is better than any other antibiotic? Is it cefazolin is better than other antibiotics? Is it the MRI because I need to look for osteo? Is it Lasix for lymphedema? Or is it pillows for lymphedema? What do you think? What's the most important aspect of acute management? Cefazolin, pillows, oh, less pillows, MRI? Okay, great. So what I want to work hard on today is to try to convince you about some of the low-tech things in soft tissue infections are actually the most important. And so we're going to touch on this. So if I had a deal to make with all of you, we worked in the same place, and I wouldn't let us get away with this, but I would let you use whatever you want antibiotic-wise in a case like this. I really don't care. But what I would say is, when I come around, I want to see this. And I'd make that deal with you, the nursing staff, the patient, the family. The biggest intervention I do when I see someone with a soft tissue infection is I get a bunch of pillows, usually a stack of them, and I make a big scene of it. I'll bring it in the room, and every time I walk in the room, invariably, I see someone in this position, or I catch them at a bad moment, they're eating or whatever. Oh, no, I've been keeping my leg up. I've been keeping my leg up. Because the number one thing why soft tissue infections don't resolve is failure to control the lymphedema. The lymphedema is that important. So I'll get the pillows and I'll say, I want to come back tomorrow morning and see you like this. The affected part has to be above the level of the heart. If it's a leg, you get pillows. If it's an arm, it's absolutely critical to turn around that lymphedema with upper extremity infections. And typically the plastic surgeons and others you might co-manage with have some great devices to do that. But this is the most important element of management. During the Q&A, if we want to talk about the antibiotic choices parenterally and so forth, I'd be happy to. But what I want to focus on in this case is recurrent cellulitis. Recurrent cellulitis, I think, is the aspect of soft tissue infections that we just don't do a good enough job in medical school or residency talking about. But it's so vitally important to understand how this works. So cellulitis, remember, is that deeper process. You got Erysipelas, which is an overwhelmingly group A strep infection, very superficial, very vivid red, striking in its appearance, but it's a PEN-VK disease. It's innocent. It's not going to hurt anybody. Cellulitis is deeper. It gets down into that subcutaneous fat layer, and it's a deeper process, less vivid in its erythema. You can't draw that margin as sharply as you can for Erysipelas. Everybody knows, everybody gets the obligatory Sharpie marker line from the ER, right, when they have a cellulitis. But if you really got precise about it and you looked, you couldn't precisely draw the edge of that erythema in most cases of cellulitis. It's a deeper process. It fades away. It fuzzes away. And what we know about cellulitis, it's an intensively lymphatic-dependent process. Remember what I said about strep, getting down into that neurovascular bundle where the lymphatics are just prime. And it destroys those microlymphatic channels. Now, there's a lot of redundancy in the lymph system, which is great, but it pays a price over time. And each time you get about a cellulitis, you destroy more of those little channels. And that basically sets you up for the next bout, and the next bout, and the next bout. So it's a vicious cycle that we have to interrupt. Lymphedema is a risk for cellulitis, and cellulitis causes lymphedema. The bugs love water. You got to do everything you can to get rid of the water. So the management of recurrent cellulitis and erysipelas means we have to stop this. And we really want to look at three things. Lymphedema leads the list. We have to manage that optimally. You have to manage any portal of entry, which oftentimes is tinea or a wound, and long-term antibiotic prophylaxis. So these are the kinds of cases we see not too uncommonly, these dramatic cases of lymphedema. A case like this you can't do a whole lot about except do your best at compression. Compression is the key for any lymphedema process. However, please don't do it when they're acutely cellulitic like this guy. So many times I'll see folks and they're trying to be wrapped and compressed when they're in the hospital with their acute cellulitis. Don't do that because cellulitis hurts. But when they're resolved their cellulitis in their home, compression is the key. Wrapping, stockings, all the tricks that you're familiar with. Seek out your local lymph expert. You got one somewhere. There's even some devices that are variable in their success, but they're out there and they can help you with edema control. This is what we want to prevent, but this is what people can be left with when they have multiple bouts of cellulitis like this guy. He thinks he's at about number 13. Larry Badur started a wonderful career by recognizing a very important association. These were folks who had saphenous vein harvest for cabbage procedures. We don't do much of that anymore, but it's well recognized that there's a subgroup of these patients that would get time after time, 15, 20 plus episodes of recurrent cellulitis in that leg. And this was a devastating thing. And what he was the one to really make the strong association was the link to tinea. Tinea pedis is an unbelievable portal of entry. You wipe out the tinea, this problem goes away. So tinea pedis is a great example of the kind of things we need to do to intervene and stop this cycle. One time I was given this kind of spiel to one of my medical students when I staffed the general medical wards a long time ago. This medical student took this to heart and he went out, he looked at all of our patients on our service. We had 14 patients. The next day he comes back during attending rounds and he said, Dr. Urban, we have 14 patients and I looked at every one of them. 9 out of 14 have tinea pedis and I'm going to wipe out tinea pedis from our service. So he took on that mission. I hope he didn't go into podiatry or something. Maybe he did. But. So what about antibiotics? This is a study published a couple years ago. It's pretty good. It's not great, but it's pretty good. And it emphasizes some points. Patients with 2 or more episodes of leg cellulitis. It was a good, well-designed trial. And what they did is they used penicillin versus placebo for a year. They put the folks on penicillin, compared it, and then they took them off penicillin and they saw what happened. There were some exclusion criteria which unfortunately apply to a lot of the patients we see. And you can see their BMIs were high, a lot of them had edema, and a lot of them had tinea. So in the prophylaxis phase, placebo about 37% recurrence, Pen 22, 45% reduction. So that's not too bad. And then when they took them off penicillin, you can see the recurrence rates basically became equivalent. So the penicillin folks lost their benefit. And overall, about half of those in the placebo group had at least one recurrence over the 3-year period. Now, there's a couple comments I want to make, and you look at the factors predictive of prophylaxis failure. If you have a lot of episodes, well, each bout sets you up for the next one. So my guy on his 13th episode, he was primed to get another one. Pre-existing edema, not surprising because you have to maximally treat that edema. That's the ball game right there. BMI, over 33. Well, maybe that speaks to the edema, the venous insufficiency risk, and so forth. But also, what about the effectiveness of a low-dose penicillin? Maybe someone with a high BMI needs 500 BID. Or I got many, many people on 1 gram twice a day of penicillin. I don't agree with their definition of failure, though. They say failure means at least one confirmed episode during the prophylaxis phase. I don't buy that at all. What your goal is in these folks is to do one of 2 things or both. Decrease the frequency, decrease the severity, or both. And what you'll find is overwhelmingly when you do this, you'll achieve a dramatic, dramatic goal. This slide, many of you, you can't go anywhere without someone knowing Dr. Mackey, Dennis Mackey, who's a world-renowned infectious disease and critical care person at UW where I work. And this slide, I'll compliment him for. 1966, JAMA. All of these are penicillin except for a couple of erythromycin. Before antibiotics, after, most of these are 0. And what you find is it works. You usually go down to 0 episodes. I don't tell people that up front. I say I want to decrease frequency, severity, or both. But truth be told, a guy like this with 3 episodes in this year alone if I put him on penicillin and he takes it, we manage lymphedema, clear up his tinea, he'll probably go to 0 episodes, which is dramatic, especially for these folks that get admitted every 12 weeks, 4 or 5 times a year, what have you. So long-term antibiotic prophylaxis, clindamycin. This is an interesting study. When clindamycin was compared to placebo, they used exceedingly low-dose clindamycin, 150 milligrams once a day for 3 months for recurrent staph infection. So a different context. This is recurrent boils, furuncles. And what they found is that 6 did not have a recurrence for at least 9 months after stopping the clinda. Why would that be? What effect would clindamycin have that would last after the antibiotic was gone? And it emphasizes one of the properties that how these drugs can differ. Clindamycin gets into the nasopharyngeal secretions. So what it does is it eradicates the carrier state in the anterior nares, whereas beta-lactams don't. So penicillin, dicloxacillin, cephalexin, none of those wipe out the staph right here. And of course, what do we do as humans? We do a lot of this, don't we? We're always doing this. And these people that have their recurrent staph infections, the staph likes to live here. So clindamycin can have some advantages of wiping out that carrier state. This is an example of a macrolide. I don't really use macrolides anymore for this long-term prophylaxis, but you could, and there's data behind that. So what to do? When do you do it? If anybody has an episode in a body part where edema can't be reversed, in my mind, they've bought the prophylaxis. Mastectomy, lymph node dissection, swollen arm, 1 episode of cellulitis, they need to be on penicillin. 2 or more episodes involving the same body part within a year otherwise. What to use? Low-dose benzathine. I've desensitized people to get them on penicillin for these recurrent strep infections. Diclox and clinda certainly can be used. The key is low dose. Low dose. People don't get C. diff. They do just fine on it. What to say? Say, let's give it a year, and let's compare it to your historical norm. If you've gotten 4 or 5 episodes in the last year on average, well, let's see how it goes. So you have to give it some time to see if it works. And then you compare it to the hassle. You got to manage the lymphedema, tinea, and those are the highest priority, and what you'll find is that it works. So back to our case, we didn't have any cultures. Blood cultures were negative, nothing to drain. He had non-purulent cellulitis, which is the contemporary way of categorizing. But remember that backdoor way of making a diagnosis of strep. The ASO is very high. So that clinched the deal. I didn't need that, but it was nice to get that back. So I finished treating him with Pen-VK, managed his tinea, sent him to physical therapy, and he's on Pen-VK to see how this goes. Okay, so in a case like this, what's the most important aspect of not acute management, but long-term management? Is it lymphedema plus Pen-VK? Is it lymphedema plus Pen-VK? Oh wait, all these are the same. This is the best audience response question you're ever going to get. All right, I think you got the point. I think what I heard was C. diff. Don't have a seizure on the... Okay, here's A, alpha. All right, 72-year-old guy, venous stasis ulcers, no increased drainage or cellulitis, and a swab. Got a swab, MRSA and Pseudomonas, put on levofloxacin for 7 days. 2 weeks later, watery diarrhea, crampy pain, got a fever, pretty tender. He's got a white count. His baseline creatinine is 0.9 and he's at 1.8. CT scans show some diverticular disease and some colonic wall thickening, but no abscess. What do you want to do? You want to start Unison for diverticulitis? Do you want to send a stool C. diff PCR and wait for the result? Do you want to send a stools for C. diff and start oral metronidazole? Send a stool and start oral vanco? Or send a stool for C. diff and start IV and oral metronidazole? Go ahead and vote. Anybody seeing much C. diff out there? We're drowning in it, absolutely drowning in it. So a lot of metronidazole. Okay. Metronidazole leads the list. Okay. C. diff is more difficult than ever. The NAP1 strains that hit the world, if you will, Canada outbreak in the 90s, early 2000s, they're everywhere. They're in your institution, they're in my institution. If your lab's not reporting them, it's because they're not looking for them. And these strains are incredibly virulent. Toxin production's higher. This is where the attributable mortality of C. diff has just risen to unprecedented levels. It used to be a nuisance disease. When a lot of us trained, oh, it's a case of C. diff, we'll treat it, too bad. But now it's dramatically changed. It's changed in so many ways. The acquisition amongst family members, the community-associated, which now are at least 20% of all the cases. You don't even have to go to the hospital anymore to get C. diff. You don't have to go to anywhere to get C. diff, just live at home. Major clinical questions remain unanswered: how to manage severe infection, recurrent infection, probiotics, and when will a vaccine be available. October, our international ID meetings, there's a couple of monoclonal antibodies that were presented, the data, and one of them made a pretty nice impact, not as much as we'd like. The monoclonal antibody against toxin B actually showed some efficacy, about a 10%, 15% drop in the rates of recurrence. The monoclonal antibody against toxin A didn't show any benefit. So we're making some progress, but we desperately need a vaccine. And it's a vaccine against the toxin. The folks who get into trouble with recurrent disease are the ones that are antibody negative against the C. diff toxin. Risk factors you're aware of. The one I want to point out and highlight are proton pump inhibitors, shown in a couple of studies to be a significant risk. So when I consult on someone with recurrent C. diff, I'm sure I'm looking for the antibiotics, but I'm also looking to stop the proton pump inhibitors if I can. What can induce C. diff? Well, any antibiotic can induce C. diff. And this is a table that we've seen and we're all familiar with. It's sort of what causes it the most, and it's Clinda and ampicillin broad-spectrum antibiotics. The NAP1 strains, those very virulent strains, are characterized by resistance to fluoroquinolones, which is one of the reasons they persist so much. Infrequently, you see some ones in the middle here, and then rare, but even the ones we use to treat C. diff can cause C. diff sometimes, but that's pretty rare. Community-associated infection is one of the most important changes. In this study, it changes in the epidemiology of C. diff. This study looked at a couple of groups that had no exposure to healthcare, outpatient healthcare, or very low level, such as going to our offices, a dental office, or some other outpatient visit. And when they looked at these groups, they were more likely to be exposed to infants or be household contacts of individuals with acute C. diff infection than in the high-risk group. So these things seem to be playing a role in driving the community-associated C. diff cases that we're seeing. Guidelines are old, and they're being updated as we speak. So the 2010 guidelines here from the Infectious Disease Society are old. And what they do is they break down some of these definitions for us. And I think the way they break them down will stay very similar in the updated guidelines. Some of the therapeutic interventions are going to change. But let's think back about the case that we had. So this gentleman came in, and anybody remember what his white count was? About 18, 19, right? His creatinine was up above baseline. So he actually meets criteria for severe C. diff. So he should have been started on vancomycin for that episode. And I'll show you some data as to why. Mild or moderate, they recommend metronidazole still. Severe, complicated, hypotension, shock, the megacolon, it's clear that you want to use vancomycin. What are you really trying to do when you treat C. diff? The mission is pretty clear. It can be challenging to achieve. You're trying to get as much antibiotic into the site of infection, into the colon, that you can. Metronidazole is an outstanding antibiotic for a lot of things. You take it, and it's got tremendous bioavailability. That's why we can treat anaerobic osteomyelitis in a mixed infection in a diabetic foot with oral metronidazole, or intra-abdominal abscess, or what have you. But what happens is when you take it orally, you absorb it, and then you have to get it to dribble into the colon through those damaged capillaries in order to get any meaningful concentration in the lumen of the colon. So it's a lot of clunky steps. Vancomycin, a Mack truck, doesn't get absorbed at all when you take it orally. It stays in the colon. It doesn't get into the blood at all. So it's the perfect drug, if you can get it into the colon, to treat C. diff. I haven't used metronidazole to treat C. diff in, I can't tell you how long, many, many years. Your stewardship people will not like me saying this, but it's what I advocate. And I would not be surprised if you see a significant change in the guidelines for treating C. diff. Now, do cases of C. diff respond to metronidazole? Absolutely. they better be very mild, and they better be, pretty healthy individuals. So at-risk hosts, the elderly who get this disease, immune-compromised, et cetera, I'm a strong advocate of vancomycin because of the pharmacokinetic properties and the fact that we have some data. This study was published several years ago, and it stratified C. diff by disease severity. This is what led to that recommendation and led to the management of our patient that I presented. What they looked at in mild and severe cases is they found a significant difference here between metronidazole and vancomycin in the response when the disease was severe. This is a look from some of the experience in Quebec with the NAP1 strains, and they looked at the risk of relapse after treatment. And basically, the clinical treatment failure with metronidazole changed. It changed as we saw a sea change in these NAP1 strains hitting our shores and really causing a lot of the disease. So you can see the treatment failure after 2003, much different. Probability of recurrence much different after metronidazole. So this study was published in 2005, and Dale Girding at Northwestern, who's done a lot of work on C. diff, had this somewhat tongue-in-cheek editorial in Clinical Infectious Disease, basically saying, well, metronidazole for C. diff, maybe it's okay for your mother-in-law, but is it okay for your mom? Would you put your mom on it? And I think it raised the question, what is the role of metronidazole in treating C. diff? So now 9 months later, our gentleman has been treated 3 times. He just finished a 2-week course, and already his stools are back. He's miserable, he's losing weight, and he doesn't want to leave his home. Anybody have any patients like this? Yeah, okay. C. diff is awful. What should we do next? 2 weeks of metronidazole, 2 weeks of rifaximin, 6 weeks of vancomycin taper, probiotics, or refer him for fecal bacterial therapy. Got the Vanco taper, probiotics. How am I doing on time? Pretty good. All right, I like it. I like it. No one bought this. No one went for rifaximin. Rifaximin has a role we still kind of struggle with trying to define what exactly that role is in managing recurrent C. diff. It's usually one of the kitchen sink items we would historically throw at people before we had this intervention. The vancomycin taper is very reasonable. I'll talk about this. We struggle with understanding probiotics, and fecal transplant, fecal bacterial therapy is very effective. Recurrent C. diff is a huge problem, and 15 to 20% of your patients will get it, and they'll get multiple episodes. Even if they don't have C. diff, there's an irritable bowel syndrome that can persist that's terrible. It's very, very bad to get this. And why do we get it? Either we don't have the antibody against the toxin, or we have dramatic alterations in the intestinal microbiome that's been shown even from a single dose of broad-spectrum antibiotics in the right individuals. The treatment of recurrent C. diff from the guidelines, this will be updated as well, talk about the first recurrence, use the same regimen as whatever you treated the initial episode, and that's how most of us were taught. Unless the initial episode is severe, then use vancomycin. The second recurrence, vanco in a tapered or pulse regimen. Other options you can see, some things that have been studied, rifaximin, Saccharomyces, plus high-dose vancomycin is really the only probiotic with literature data to support its use in the context of recurrent C. diff, modestly effective. Nitazoxanide, IVIG, with the thought being to give back the antibody against the toxin, fecal bacterial therapy. The guidelines came out before fidaxomicin was on board. Fidaxomicin is an antibiotic that was compared to vancomycin and shown to be equally efficacious in treating the episode of C. diff, but had lower recurrence rates. So it is an option. 10-day course, very expensive. So we don't use it much personally, but it is an option. Let's talk about this. The vancomycin taper pulse. This is advocated in the guidelines, but you actually won't find a literature reference for it. What you'll find is there's a classic study by Fran Tedesco in the mid-'80s who actually used a vancomycin taper. And this is my recipe. And the recipe really derives from John Bartlett from Hopkins and A.W. Karchmer from Harvard in some of the work they did about the pathogenesis of C. diff. So here's how C. diff works. C. diff gets studied in a hamster animal model. If you give hamsters C. diff, they all die, 100% of them. If you put them on vancomycin, they'll live. You take the vancomycin away, they'll die. So hamster model has been used to study how C. diff works. And the idea here is we're going to give a high dose and taper it over several weeks. And then this is called the vancomycin taper. Look at this every third day for 6 weeks. What's that all about? That's the pulse. And if I were to, usually when I ask people, what do you think the pulse is for? What do you think this low dose is for? Most people would say, well, there's probably a few C. diff hanging around and we're going to just, treat those residual organisms. Remember, this C. diff exists in a spore that has to change to its vegetative form and make a toxin. What actually happens in this hamster model is this low dose, this very low dose every 3 days, it keeps the organism locked up in the spore form. It keeps it locked up in the spore form. So the idea is you keep it locked, you kill the vegetative organisms making toxin here, you keep it locked up in a spore form, and you allow the intestinal population to repopulate. And that takes about 6 weeks if you don't have any other things getting in the way, like another antibiotic and so forth. So that's the idea behind this. It's pretty neat, and it works. It works pretty well in my experience. Duodenal infusion, fecal transplant, this study showed that the success rate's 80–90% compared to vancomycin. Very low in this study at about 30%, but this has really made a dramatic impact on the management of recurrent C. diff. From the annals recently, summary results, patients with resolution of symptoms. No, it didn't really matter how it was given, the fecal transplantation via NG tube, enema, colonoscopy. There's many different ways to do it. The rates are all very high, and they're the most successful rates, the most successful intervention that we've seen to date for recurrent C. diff. So our patient was referred for fecal bacterial therapy. His daughter was the donor. His vancomycin was stopped before the procedure, and the donors are screened for a variety of infectious diseases. In our institution, our fecal transplants are done at our GI center, and it's an enema. They get an enema on site, and then they take home an enema to do at home, so it's 2 different enemas. And his stools were normal after 2 days, and he actually made a doctor education card. And he made this card. I think he found this on Up to Date. There's a similar table, I think, on Up to Date. And he said, every time he told me, he said, every time I go to an urgent care or ER, I'm going to pull out this card if they want to put me on antibiotics. And so I was kind of proud of that. So my approach to recurrent C. diff, if someone recurs, I will try vancomycin for a couple of weeks. Again, you're retreating just to see if you can make it stop there. If not, I'll do the taper pulse. If they relapse after that, then I refer to fecal bacterial therapy. What you're going to see in your practice is that this will move up higher on the list earlier. We won't mess around with so much vancomycin at some point in time, especially when we get to the point where you can deliver the fecal bacterial therapy via capsules, freeze-dried, et cetera. There's a lot of work going on to make this a more appealing sort of situation than what a lot of people think. Do everything you can to avoid antibiotics. So let's go back to one more question here. What else could we have done in this case? Anything else we could have done back when it started? Yeah. A course of what? Well, this is our guy, and he had venous stasis ulcers, and he had a swab culture, and he was put on levo. Lamisil? Yeah, in this case, he really didn't have a fungal infection, but yeah, not to confuse, for that cellulitis case I presented earlier, that would be a good idea. But what could we have done here, maybe? What's that? No swab cultures, right. There's no reason to get a swab culture. They predict nothing except colonization. And if the levo would have been avoided, the cycle never would have started. So the point just is avoid unnecessary antibiotics. Okay? Good. All right. Let's see here. 7:35. Can I do a quickie? I got 5 minutes. I have 5 minutes. All right. This one's pretty fast.
Could you go over why that last case wasn't reinfection versus recurrence?
Oh, sure. Happy to. We often can't tell the difference, and practically speaking, reinfection of C. diff versus a relapse, a true relapse. And so depending on the circumstance, the epidemiology, but a lot of people are at risk for both. And practically speaking, we simply can't tell the difference. What you'll find sometimes is people will have some gaps between when their diarrhea resolves and they get another episode back, and why it takes time, probably alterations in the microbiome as much as anything. But yeah, we practically speaking, and we know that both happen, but we can't really tell them apart.
And toxin A, toxin B?
They're both bad, and the NAP1 strain has an additional toxin that probably enhances the effect of this. But toxin B seems to be the bad one, and the monoclonal antibody that we recently got some data for actually has some effectiveness when it was against toxin B as opposed to toxin A. So all of them are bad. B has some significance. The NAP1 strains not only produce more toxin of either sort, but they have a third toxin, a binary toxin, that actually has some enhanced virulence as well. Yeah? Sure.
Notice any decreased post-infectious IDS with fecal therapy versus antibiotics?
Yes. Have we noticed decreased? I'm unaware of any studies. Maybe there are some out there. Anecdotally, in the patients that have gotten fecal bacterial therapy, they've done really, really well. I've sent several patients for this, and I'm not the one directly organizing it where I work, but it's unbelievably effective. Has anybody sent patients for fecal bacterial therapy? What's your experience been with it?
Pretty good.
Pretty good. Their symptoms go away, and these are people that often are miserable, been miserable for months. They go away typically within a day or two. It's well tolerated, and I had a gentleman who went through this after being tortured with C. diff for over a year. Then he went for a pacemaker, got a dose of cefazolin, and it came right back. So we've had to retreat. We've had one case of a refractory C. diff in our bone marrow transplant unit that nothing could touch this, and they got a fecal bacterial therapy actually in the hospital that resolved that episode. And I'm not advocating you do this as a routine, but don't be surprised if at some point we start moving this intervention up to select individuals, not only for the recurrent situation, but for other situations too. And the point of me sharing that with you is just there's a lot of work going into other applications. And what you're really going to see is a change of delivery type and how to do this in a more palatable way. Dr. Steiner?
So we find that case mortality from C. diff is particularly high in elderly geriatric population and also in the in-hospital population. So can you tell us what the current thinking is about the use of probiotics, number one, when patients come into the hospital and get put on an antibiotic?
Right.
And to prevent this, and number two is, maybe, you might have touched on it earlier, the role of PPIs as a predisposing.
Yeah, thank you. Yeah, I did mention PPIs and highlighted that. So you concur with the PPI risk? Yeah. So, well, there you go. Excellent. Yeah, so I actually, on a sea of risk factors, that's the one I highlighted because I think it's very relevant. And in terms of probiotics, we struggle with this. We struggle with it in a variety of ways. It's easy to say probiotic, and our patients are getting them, but what exactly is a probiotic? And it's actually a strict definition. And most of the things people go to the stores and buy are not probiotics. They're not live organisms with a certain amount of viability and so forth. So we don't know what they're taking and getting oftentimes. A couple of studies, not all, and very few have showed any positive benefit. Probably the best was from the UK and hospitalized elderly patients at risk for C. diff. And basically they used the same kind of probiotic that is in, it's the active part of Dan Active yogurt. It's the European version of it. I can't remember what they call it there. But if you look for data, that's probably the best data. And what we tell people is if you're going to buy something, and I don't, I have a hard time recommending things that cost a lot of money that I really can't tell people that I know are going to help them. But if you're going to go out and buy something, that the active organisms in Dan Active yogurt have been studied and had some effect. And that was in preventing C. diff in hospitalized patients. So you get into this situation in terms of recurrent C. diff and so forth, and we really don't know what to recommend, and hopefully we'll get some answers there. One of the problems is we think of a probiotic, and it has, the way the studies are done, it's studying something. But how do we know what that something is the right thing? Maybe it's a collection of organisms, and what's the right dose, and what's the right frequency? So all these variables are very challenging to study.